Hi, I'm Matthew Herzberg, and this is the Myopia Mindset. This podcast is your weekly check-in for inspiration, education, and motivation on your path towards success with myopia management. And my guest today is none other than Dr. Cary Herzberg. He is a pioneer of the myopia industry. He's one of the founding fathers of orthokeratology in modern practice and myopia management as a specialty. He's past president and founder of the American Academy of Orthokeratology and Myopia Control, as well as the International Academy equivalent. And he has helped shape the future, the present and the future of our industry, including so many current eye care professionals who are doing myopia management and doing it successfully. Cary Herzberg, welcome back to the program.
Well, thanks, Matt. It's a pleasure to be here.
And in addition, Cary is also my dad. I grew up in his practice. I guess I would have been the equivalent of a myopia coordinator in your practice. I was a staff member, part of the process, and I've also been the past executive director of the American Academy of Orthokeratology and Myopia Control. The two of us have had a bit of a perspective over the last 20-something years, growing and developing this specialty in eye care.
It's amazing to watch it develop, because back in the day, we could maybe count 100 people or so that were actually really invested in this, and the rest of our colleagues were really neutral or anti. So we've come a long way now, where you actually have some momentum to work with.
And I feel like this momentum's a great way to put it, Cary, because I feel like this is a time period of momentum. Where we're currently now, we're recording this at, November 13th, 2025 is when we're recording this episode. This is at a critical moment, I believe, where the industry really, in the community, larger community, needs to come together around the idea that myopia is a disease. And I think that's really the crux of this episode, because, a lot of what's been leading up to this episode is Sidnexis, right? A low dose atropine drop that was under consideration for FDA approval. Recently at the Vision by Design conference, we discovered that FDA approval had been halted or delayed. And that was to say it's a bummer is an understatement. It's a very frustrating moment for us. And I wanted to go into the FDA approval and this moment, because everybody is weighing in on this. You're seeing Mark Bullimore released a statement on this. The AAOMC has released an official statement on this. David Kading from the Myopia podcast has
Alan Glazer.
Yeah. So everyone is kind of chiming in on this moment. I feel like this is going to be one of those pivotal moments where we as the community can come together and stress this idea that myopia is a disease and what this means for us moving forward. So what I'd like to do is I'll start with, talking about the AAOMC's statement, because they recently they issued it just today. The American Academy of Orthokeratology and Myopia Control has issued a new statement reaffirming that myopia is a chronic progressive disease and highlighting a major regulatory gap in the United States. While the FDA has cleared multiple device-based tools to slow myopia progression, its drug division has not recognized or approved pharmaceutical treatments, including SID-101 low-dose atropine. Meanwhile, global regulators are moving ahead. SID-101 low-dose atropine received approval in the European Union and just recently the United Kingdom, reflecting growing international consensus that early treatment is essential to reduce long-term risks like retinal detachment, myopic maculopathy. The AAOMC says that the evidence is clear low-dose atropine is effective, safe, and should be part of comprehensive myopia management. The organization is calling for a formal disease recognition in the U.S. policy, better access to pharmaceutical treatments, and stronger integration of atropine into clinical care. Cary, you have been ringing this bell for a long time about, myopia as a progressive disease.
Yes.
So let's start there. Like, when was this on your radar? When did you start vocalizing this as a concept?
Yeah, back in the early 80s, it occurred to me that that my patients were returning, for more frequent follow-ups. In fact, back in optometry back in the day, after your patient would graduate college, they really didn't come back to your practice again until they were over 40 because their eyes didn't change very much. Then all of a sudden, into the 80s, we saw the increases in prevalence of visits, and the myopia started, progressing. Even at that point, at the same time, we saw, changes in obesity and diabetes, were also increasing. And this was all, we started to track what's happening in the workplace, what's happening in the environment of these patients, and a lot of them were getting these workstations. The IBM workstation had come out just then, and they were spending a lot more time on near point and computers and spent less time on outdoors. They were becoming more couch potato like. So it was even back in the 80s that it started. And so I decided, this became such an issue because my patients were coming back for increases in prescription. And to me, myopia is a drug, and the prescription is a drug that you're treating this, higher and higher prescriptions. It's like it's dosing. So I felt like I don't really want to be part of this process, of watching my patient's vision getting worse. I'd begun adapting a model of preventive care before this, and my goal was to incorporate preventive care in my practice, which I was successful at doing. And part of that was, a majority of it was done through Ortho-K at that time, which was really our only way of controlling myopia. Now today we have many, many more, which is wonderful. So, it became just a mission statement for me. Mm-hmm. That myopia would not increase. Put the stop sign up there, and I borrowed a lot from the Chinese medicine model, which said that if your patient gets sick, it's on your watch, so you're responsible for your patient's health. So basically, what was going on at the same time, Matt, and what we got to really fight and we're very wary of, is if you don't look at it this way, if you look at myopia as being a genetic disorder, and that was the prevalent thought at the time in the 80s. Then there's no responsibility for us clinicians on it. I mean, what difference does it make that it's just going to get worse, right?
Right.
So it's a responsibility thing, and we need to take hold of this thing, and it's past time that this is called a disease that it is,
Right.
So, yeah.
Yeah. And that's one of the reasons why I wanted to have you on for this specific episode, because, my limitation is, I'm not a clinician. I'm the equivalent of, I don't like using the word influencer. I'm more of a myopia industry communicator is, I guess, how I'd like to look at it. So I want you to speak to some very specific talking points that I think cannot be stressed enough. And the first one I want you to address is, typically this is just thought of as a refractive error.
Right.
And instead we're looking at the elongation of the eye,
Mm-hmm.
and why has this been such a big stumbling block on our way to classifying, pediatric progressive myopia as a chronic disease?
I think it goes back to the old days again, where you were thinking about, this is a refractive condition, and not only that, but it's a profit center for a practice. The more pair of glasses you make for a patient, you get to change it every 6 months. Like that's, another extra pair of glasses during the year. So it's a profit engine. And so when you talk about, then you want to get into the other aspects of this, which is basically to stop it, the progression, you're actually, affecting that. The other thing I think that happens at the same time is that we as eye care practitioners have failed really to really separate our practices into goods and services. I think, it's past time. I mean, I was told this by the AOA back in the late 1980s that we should be putting the definite amounts of cost into a procedure, the services rather than the materials. Become less dependent on material pricing, which can fluctuate dramatically. And as we know on the internet, God help you. So, this is a necessary thing for us. And I think we as ODs fail to get that to the point of even talking about it with the patient, because I think we're embarrassed to say that we're really worth this, that our time is worth this. So this has been a battle from the beginning, to get the thing put into services from materials. And so again, if you're going to charge for services rather than materials, then you're going to have to see the patient more often. And a lot of times these vision care models that are out there, these vision care plans work against that because they're not paying you a lot for those services. And so you generally can't spend the time with the patient. So this dichotomy is like a Jekyll and Hyde. How can you live in this situation where, you're pitted against yourself? If I spend time working with my patient talking about preventive care, then, I've got to charge for that. And yet, if I do that with vision care plan patients, I'm not going to get any reward for doing that at all. In fact, it's going to worsen my outlook as far as being profitability.
Right. And there's an obligation to do something about it, right? That's a kind of a come to Jesus moment, right? A lot of the public, as far as they're concerned, single vision glasses is the answer, but that doesn't solve this problem. It's frustrating to watch the public react to myopia. It's like, well, what's the big deal? So you have glasses, a lot of people would say that, but the glasses don't address the issue.
No, and this is a costly thing. It costs the healthcare system. If we talk about myopia, if you have increases in prescription for every diopter that increases, that's preventable. You're increasing 40% the risk of myopic macular degen, maculopathy, which is the number one cause of blindness in the world today. And when you think about the fact that there's going to be 50% of us are going to be nearsighted by 2050. And that the high percentage, a percentage of those, not a high percentage, but significant, because it's about 10% of those will become high myopes. That's when the numbers really start to jump. But I think really the key thing here, what we need to talk about, is the fact that any degree of myopia really is a risk factor for these things. I mean, this is a condition that, though it's not preventable, it's controllable. And we as eye care practitioners, this is our wheelhouse. We should be doing things for our patients that prevent the progression of myopia. Simply said.
Yeah. And, one of the best ways to communicate this is, in the past, we didn't really have the tools that we have today, like orthokeratology or peripheral defocus, soft lenses. And what we had hoped would be FDA approved atropine.
I know.
Because early intervention is, you talk about preventative care, right? Early intervention is absolutely key to addressing this problem. Can you speak more about that? Because I know preventative care is a huge part of your practice.
You've got, it is. It's the practice. Basically, we work with that. It's one of the reasons why I chose pediatrics, because the geriatric population, it's very difficult to, I've had patients walk out on me when I've told them they need to lose weight. They're diabetic and they may want to lose some weight to control the diabetes. And so, the kids are easier to work with because they listen, and they actually might do what might take what you're suggesting to and do it. So it's much easier to work with those younger patients. But, I think it's, when you define this and you look at this, it really falls down into the category of, how do I, it's again, mission statements. How do I look at what I'm here for? If I'm here to make a huge profit on things, and make a lot of money, then I'm in the wrong profession, right? I should be maybe a stockbroker or something. So, you have to kind of equate both of these things that go on. And I've always been rewarded by spending more time with my patients. I can make that statement. It's true. And so any way you can find in your practice to do this, to spend more time with your patients, if it involves then even taking less vision care plan patients and more, patients that will pay out of pocket, then you need to do that, because you need to spend time with your patients. That's just it's a human thing. You'd want this done for yourself. It's the same saw that, do unto others as you do unto yourself. That little child there is the same. You should treat the same as your own child or your grandchildren. So I always felt that was the philosophy I went in with, and so it made it easier for me to take that route, that course, even when sometimes it wasn't the greatest thing for my bottom line.
Right. And as someone who grew up in your practice as a staff member, your practice being a pioneer orthokeratology and myopia management practice, we
basically started.
Right. We saw, parents that came in with their kids that were having the issues that the parents had, but the parents didn't have them until after college or college age.
Right.
And they were starting to see worse prescriptions in their children. And those were like the early day bread and butter cases of myopia management. And I know that treatments, like atropine has been on the radar, but let's talk about why this is so important, right? Because you mentioned the year 2050, right? The myopia epidemic. Why is this so important?
LDA, low dose is the first line of defense against myopia. I mean, basically, if the child is, you can't do anything else with that child, maybe due to age or whatever, you can drop them, you can put drops in. And the statement that the FDA is making, that they pulled away from this, is not a great statement. It's not a comforting statement to the industry. It's a threat to all of us who are trying to control this myopia thing. And it's really kind of like how do you phrase this thing? It's I don't know where this is coming from. Okay, because if you can, if the devices get approved, why not low dose atropine? And so you're hitting at the heart of what we do as a professional, as an eye doctor, to care for this. And I've heard instances even now since they've done that actually some doctors have just pulled away from using low dose atropine entirely because the FDA gave this mixed message on what they were talking about. So here we are, with a patient that maybe not mature enough to wear contact lenses, or even put glasses on for that matter, maybe due to an age, it doesn't work that well. And so here you can drop the patient and get a reasonable, reduction in myopia progression. I was at the major meeting that happened at the start of this whole thing back in the day. It wasn't even that long ago anymore, but it was in Washington D.C. and we met with the FDA, and they were talking about what was meaningful for myopia. If you control a 50%, is that meaningful? If you control a 30%, is that meaningful? And we came across with the fact is that any of these amounts that you decrease the progression of myopia by reduces the amount of high myopia you're going to see. Sometimes very significantly. In other words, if you reduce myopia by 50%, you use whatever will reduce the myopia progression by 50%. You're going to reduce high myopia by 75%. I mean, if you start young enough, I mean, that's what is that? What are we talking about? I mean, back in 2015, the industry spent $244 billion dealing with the myopia itself, as far as what the bad effects from myopia, as far as you missed work and everything else, what myopia really means, because it is, affects your efficiency, your productivity. It's a limiting thing for anybody who has to deal with that. Your kids are, they can't be free of that. I mean, so they can't see with without glasses on. I mean, it's a dependency they develop. So that was back in 2015, and this is $244 billion. Imagine what that is today, over $1 trillion. At least these are big dollars that you can affect and save all of us from the healthcare system, and I think we as healthcare providers, I mean, this is our music. This is our theme, is to, prevention, is to control this thing. So they're hitting at the heart when they do this strange decision that they had, which doesn't have any foundation, I think, from what I understand from what happened here. They're hurting all of us. They're hurting myopia. They're hurting prevention of myopia. I mean, basically, it's challenging the question of, is myopia really a disease? And that's why I think we need to rally all of us in industry together to come on, to end this discussion. It is a disease. Any degree of myopia causes a 40% one doctor will cause a 40% increase in the possibility of getting myopic maculopathy. So
for sure. And that's what I appreciate about the AAOMC's official statement on this, because their call to action is like, hey, we need to all come together and communicate why this is important. And, for my part, having a source of FDA approved low dose atropine is so important, because I have worked with and around ECPs doing myopia management, clinicians, and so there is such a barrier to entry for a lot of docs who are looking to get into myopia management. And the problems with atropine in the past has been consistency, how it's made, how it's stored, its shelf life, all of these different factors.
This was all going to be answered with a excellent product that we're talking about here.
I mean, you would say, like, correct me if I'm wrong here, as the expert on the episode here, if more ECPs had quality FDA approved low dose atropine as an intervention that they could immediately put into effect, what kind of
oh my gosh,
what would that mean?
Let's be straight on this whole thing. Okay. There are many of us. I mean, okay. There, us pioneers, and we talked about this. Sometimes we would go into things without knowing the outcomes. I mean, because that's what happens to a pioneer. I mean, you
Hmm.
go, you blaze a trail right to something, to whoever it is. It's a pioneer thing. There are many doctors that are not pioneers. They do not want to blaze trails. They want to have repeatability and comfort in the practice. They want to go home and greet the wife and kids and not have to worry about what's happening with the patient, right? So the fact that you can have an FDA approved product, and I applaud the Stellus approval. Let's get a lot more going on that
For
thing,
sure.
and more of those dual focus soft lenses, that are coming to market here to get those approved. But that takes a resistance band away. That
Hmm.
gives them another, push towards let's do this. I mean, come on, we do drops all the time. Why can't we do low dose atropine with children who, are susceptible to myopia progression and just take care of it, And so for
Right.
doctors that don't want to get involved with wearing contact lenses, some doctors don't like to fit kids with contacts. Some doctors, don't want to do ortho-K or other, all the resistance bands that are out there for different applications, and, or, when you're using Stellus, is the patient the right age? What are the factors here that are going to be a problem for you? Atropine is easy peasy. Put the drops in. Open your eyes, put a drop in. That's what we
Right.
do for a living. So this is something that's core, and it is, I think, a threat here that they have to pull back from this. A threat to our whole industry that's depending on, support from everyone, including the FDA, to
Yeah.
authorize the use of this because it's safe and it's effective. So let's get off our duff and get this done. I mean, it's time. I've been doing this. I've been doing this myopia thing since the early '80s. Come on, you know what? Our goal always was to make it easier for the next users,
Right.
whether it
The
be
next gen.
ortho-K, or myopia, anything in myopia management. And so, we did that. But it wasn't. It's not been fast enough, in my
Hmm.
opinion, because we deal with different challenges, right, as we go along here. And some of those have been the industry itself. Okay,
Right.
the support that industry gives you and the powers that be that we're all dependent on, whatever it is. And so now it's time for that whole thing to line up. All right, we're past due on this. This is like there's money owed here. There's time to apply what we need and to have done and to control this problem. We know we have a problem. Myopia is a disease. It needs to be treated early. It needs to be as much of it prevented as possible. Axial length is important. You need to do more follow-up for your patients, and we need to have everybody pulling.
Right. Yeah. Very well said. It's exceptionally frustrating from my perspective as somebody who has been a part of this industry, not as a clinician, but working with and around clinicians who specialize in myopia management, because SID 101 has been, approved in Europe, in the UK, other parts of the world, under a different name. I had it right in front of me. Rejunia, I think is what
Yes,
it's called in Europe. I hope I'm
right.
pronouncing that correctly. But then as I started looking into this, because this is where I started to see some of the their information. SID 101 was tested in the STAR trial. Do you know anything about the STAR
Yeah,
trial? It's
it had, well, we could read, actually, the statement would give you the particulars. I hate to use my memory, but it's quite extensive. I think it was close to 1,000 patients they looked at over a period of time.
Yeah, it
And
was like
yeah,
850 or something patients.
yeah,
Yeah,
and
over like 3 years.
right. And, the patients, it was done, it was a incredibly well structured and executed study. And it showed definitely the effectiveness of low dose atropine in the study. And so this was even what the FDA had required them to do, is to do this kind of a study to get it done. And they did it. And it's still
Hmm.
not good enough. So, there is not, there's not a component here. It's a head scratcher, Matt. There's not
Yeah.
anything here that you can come up with reasonably to find a reason why they hesitated in approving this product.
Yeah. I mean, there's so many docs out there who need FDA approved solutions in order to start
Yeah.
implementing myopia management. And I cannot stress this enough, having worked with clinicians doing myopia management most of my life, is that you want to eliminate the barriers to entry. Orthokeratology is a treatment that needs a lot of time and investment that the
Hmm.
modern ECP may not be able to jump right into. even the peripheral defocus soft lenses or the Stellest
Yes.
glasses that just got approved. I think that's what's the high point of my frustration is I've seen this firsthand. It's like if they had a solution in place, think about how we could grow myopia management that much faster,
Oh,
right? Like
yeah.
we desperately need kind of like an easy button in myopia management. And I felt like, Sidnexis's FDA drops were gonna be that.
Yeah, it opens up a whole pathway to different applications and ways to deal with it. Yeah, I've been talking to doctors since the Stellus approval, and they've been, God bless them, they've done a lot of Stellus lenses now. And they said
Right.
there's an education that's involved with the patient. You have to sit
Right.
down and educate. It just isn't prescribing a pair of glasses. This is myopia that we're talking
Right.
about. And the other thing I wanted to talk about is informed consent. Okay, now I grew up with this is off label. This is ortho for myopia is off label. Okay. Until we get a
Yeah.
study done that shows 2 or 3 week washout periods where the patient's taken out of the lenses and shows the prescription is not changing, then we have to deal with that, But so, I've gone blue in the face talking about informed consent, and you still need to do informed consent. But I mean, a lot of applications I've done in my past have been off label.
Right.
I have yearned for the day we could do on label, that I didn't have to say that again to a patient, And so here we go, we got my site, hallelujah, on label. Now we got, Stellus, hallelujah, on label. Now I was hoping we'd get LDA on label,
Right.
not off label, because it's time to, add that repertoire, part of your repertoire to an FDA approved device, application. So, to this drug. So I think, we're past time when we need to start, getting it. It's again, we talked about it before. It's just getting all the, your dots dotted and the T's crossed. It's time for industry. It's time for the agencies that control and regulate this thing to really get their act together, because we have a problem here. Hello, Houston. There's a problem here. Okay.
Yeah.
It's called myopia. It's a progressive disorder that can lead to blindness. It has, it's not going to affect you when you're little, when it's happening. It's going to affect you when you're into your 5th, 6th, and 7th generations, decades, 5th and 6th, 7th decades of life, where this will come back to, to deal with, and to deal with it. It can be devastating. Let's stop this. Let's make a better future for all of our kids.
Yeah. When you think of so many things in healthcare from the preventative care aspect, as far as like addressing major health issues and problems, disorders, and complications, like smoking, for instance, intervening and on that, has improved the quality of life and the health for, people the world over. And I feel like, this is like how do we not look at our sight as one of the most important things in life as far as quality of life and our health? It just boggles my mind that, this has not been declared a disease yet.
I know.
And what is it going to take to do that? In your opinion?
You think back at it for a moment. Let's take a retrospective look at it. But before 1960, okay, they thought that they didn't know that blindness could be caused from a high hypertension. Before 1960, they developed the drugs to deal with hypertension, but they had no clue that hypertension actually caused blindness. 1970s, you saw the first medications, the first treatments for glaucoma as a disease process. Okay. And even today with glaucoma, there's an argument, what exactly is the mechanism that's causing the problem? Is it a brain? Is it an eye thing? They're still debating all this, but there was no problem approving drugs supposedly for treating this thing. Is the optimum goal in glaucoma to lower the eye pressure, or is it something else we've been getting at here? But there was no problem, no barrier to approving these products, even though today we still wonder, is that the main mechanism or not? Is that the way we should be controlling it? In glaucoma. Yeah. In the mid 1990s, I sat through lectures that didn't really know if there's an association between glaucoma and myopia. Okay, I heard this from the podium. They couldn't make an association. So I mean, do we have a pattern here?
Right.
You can go and debate this all you want, but it's the same argument. I mean, you look at vitamins. We looked at back in the day. It was questionable: should you or shouldn't you prescribe vitamins? I'm talking in the 80s.
Hmm.
is this beneficial? Well, if I had waited, until all the data was in and we collected everything that was there to document, I would have lost a generation of patients that benefited from, the treatments with that. So there, there isn't really a barrier here to why this isn't approved. I don't see it, man. I cannot figure this out, why we don't have an approval at this moment for low dose atropine. And I am sympathetic to Synexus and the company in sympathy for their frustration, because they've done everything that I can detect correctly.
Right. It's a frustration we all share. And that's what I want to close on. This is like, I was really inspired by the AAOMC statement. I think that the AAOMC should lead in this particular case and try to bring the industry and the community together. And so I would, put that challenge towards the rest of our community and our industry. If you're an optometrist, if you believe in myopia management, then your voice needs to be heard on this. So put it in the comments of this episode, or put it out on social media. Like let's get heard on this, because
that's right. Let's make it known.
And it's not about Synexus. It's about the importance of the FDA approval for a low dose atropine option. Because as you pointed out, we have MySight and Stellus, and so we need to continue here. So that's my challenge. Lend your voice to this effort. Let's join the AAOMC and getting it out there and getting it heard. Let's build momentum and really put a spotlight on myopia as a disease.
Yes, I absolutely applaud that. And the other thing to think about as practitioners, if you're really concerned about myopia, well, get involved with myopia organizations. The AAOMC has it in their name. They've been, believe me, I'm the founder of this group.
Yeah.
This was our intention from the beginning, to be my myopia-centric organization, to controlling myopia. This is how I started, basically in my preventive care practice. That's what it's about. So join, look into this group, join it if you can. It's the theme song is there. You don't have to it doesn't have to specifically be an orthocentric group. They're actually doing a lot with all the different aids, and you should read the Google group that they come across with all the dialogue now that's going on. They have webinars dealing with Stellus. So, go ahead and show that interest. Put your attention to it, because that brings, growth for all of us.
Right. Yeah. And if you're not sure on how to communicate this, like I said, the AAOMC has put out a couple of statements. One of them is actually parent and patient focused. I'll put some contact information or some links. I'll reach out to them to see if we can find a way to get that into your hands to arm you as far as having this conversation confidently. Because the more, the AAOMC in the past has been really good about helping to bring everybody together and unify around these kind of messages. And I think this is one of those moments, and I hope that we can get this changed.
Yeah, I was in Europe when MySight Cooper was over there, and we were having the European meeting at the time, and they got their approval, which was an historic moment, because the first device approval for myopia control device approval. And so that was something for me. That was a big deal. And we made a celebration for them and everything else. It was a big moment. Let's do another one. Let's have another big moment for low dose atropine.
Yeah. Right. And this is one that you can be a part of. If you are a practitioner who does myopia management, or hell, even if you're interested in it, this is, like I said, it's a come to Jesus moment when you realize that myopia is something that needs to be addressed, and there are solutions out there in order to treat your patients. So be a part of that solution. This is what you went to optometry school to make a difference. And this is your opportunity to do so. So let's make this message as loud as we can.
Live the dream. You had when you went to school, you had, altruistic ideas of what you wanted to do with your life and yourself and how you wanted to have that play out. Well, now you can live the dream. Myopia control is the best stuff going, helping little kids. Let me tell you, I have now done over 40 years of experience with Ortho-K itself, 35 years, the longest wearing patient of an Ortho-K lens. And I'm only stating that because it does make a difference in people's lives. Okay.
It sure does.
It sure does. It changes, and they know it. Okay. And they go on to other careers, and sometimes they're, ophthalmology, other things, and they'll tell you so, and they keep coming back because you are doing something very meaningful for them, and they realize the benefit. Okay. So enjoy it. Go out there, live the life that you were born to. Let's do some prevention.
Right. Yeah, well said. And you can reach out to the AAOMC at aaomc.org if you're interested in more about this podcast and everything that we're doing here, because we believe that myopia management is the best thing ever and more ECPs should be doing this specialty. And if that's something you'd like to be a part of, help support our mission at myopiamindset.com. Cary, if anybody has any questions for you, how can they get in touch with you online?
Yeah, the old-fashioned way, by email. OAADOC@gmail.
I love that email is now considered an old-fashioned form of communication.
Don't you love that? Yeah. So the old-fashioned way.
Yeah, for sure. Yeah, and you can reach us at myopiamindset@gmail.com in addition to that. And I hope that you do, because like I said, this podcast is meant for you to listen to on your way to the practice, or as you're wrapping up at the end of the day, or while you're washing dishes or walking the dog. You can listen to us and get fired up about doing this.
Yeah, I want to tell a little story before we're done.
Oh, yeah, go ahead.
Okay, so Matt here is responsible for myopia control in Trinidad. Okay. Because he started this thing, when he was working for the AAOMC, he did these podcasts, and a doctor in Trinidad listened to his podcast and got excited. Wasn't having much success with Orthokeratology at the time, got fitting lenses at that time, and through Matt's podcast, they became much more successful, came to our meeting to meet him personally, and had come to the most previous meeting. And now she tells us that doctors in Trinidad are now, there's 3 more doctors are doing myopia management control in Trinidad, and this is the guy sitting right here who's responsible for that. That's what it means for you as eye doctors. Take hold of this thing, take control of this thing, change people's lives for the better. I mean, that's what we were really born to do, I think, make life better. This is the idea. Have the next generation be better than what we had to deal with. So let's all do it. Let's all make that push. Use this guy as an example. He's a living example of making a difference. Okay. And surely we all can do the same, right? Let's make it happen.
All right. Well, thank you for that. And, yep. So that's going to be it for this episode. So Cary, thanks again for coming on, and for everybody else, we will see you at the next one.